Okay, we are live now. Sir, we can start the program.
Yeah, yeah, we can start.
Yes, sir. Let's start.
Good evening to all of you. All of you are aware that this is a month of autism awareness and autism awareness month. So we have started a program based on this, and today we have three speakers who will be talking in different aspects. One is Dr. Parthapatim Bora, well-known pediatrician. He works on developmental pediatrics. He's HOD at the Pratiksha Hospital. He's a coordinator, national coordinator of CAP module. And we have second speaker, Mrs. Pritishmita Sharma. She is a consultant SLP in Patidwani, visiting consultant at Pratiksha Hospital and Vibora Cancer Institute. She also worked in AII PMR Mumbai as an SLP. She has done her bachelor's and master's from Ayush Mysore. She is also certified, AWAS certified of ASD trainer. And we have the third speaker, Dr. Manishi Devi. She's an occupational therapist, presently working in Pratiksha Hospital as early intervention occupational therapist and visiting Astita Attiga also. She is a registered occupational therapist under AIOTA Academic Council of Occupational Therapists India and Allied Healthcare Professionals Council Singapore. Totally 10 years of experience in her field, have extensive training and experience in the early intervention and overseas. Only OT from Assam who is certified in CIMT, University of Alabama, and she is routine-based interventionist on from Australia. So she has an extensive work on occupational therapy. So since ASD is emerging topics and emerging subject, many children are affected with ASD. So I think this discussion will be a hot discussion today. Let's start the discussion with Dr. Parthapatim Bora. Parthapatim Bora, please.
Thank you, sir, Biswas sir, for the introduction, and of course, first of all, my thanks and gratitude to all the participants for taking out time on this Sunday evening, and especially on the during this festival of Bihu. Everybody has taken out time to take at least to make us aware and to feel and to be a part of the this awareness campaign or the awareness week. My thanks to Pritishmita also. As intelligently, Pritishmita has given me a topic, and that is sleep disorders in ASD. I hope, and sleep, when I was talking with my colleagues this morning, they said that the sleep, you are going to talk on sleep and you're the first talk. Hope you don't make sleep, all the participants don't go to sleep after your talk. So I hope everybody will be able to highlight some of the important aspects of sleep and how relevant or how important is sleep, especially in this subgroup of patients or population, especially in children with neurodevelopmental disorders or children with autistic spectrum disorders. I'll just share my screen. I hope my screen is visible and audible.
Yeah.
Okay. So our topic for today is the sleep disorders in children with ASD. As we know, sleep is a very important topic, and sleep is something which we hardly discuss. And sleep is something which is, I think, especially in the pediatric age group, I think most of the parents also, they think it's just a part of the part of life. As the baby grows, baby sleep, things are going to improve. But it is very important that the baby sleeps throughout the night. The baby sleeps as it follows a particular routine, and sleep has got an immense importance, especially in the neurodevelopment as well as the growth of a child. It is seen that if a child sleeps properly and with a good night's sleep, there'll have proper growth and development. It enhances memory, basically. If you know that the different hormones that are secreted during our sleep, it usually helps us in the cognitive development, as well as it also helps in consolidation of our memory. It also increases the attention span. A child who can sleep properly at night, the child who sleeps throughout the night properly, will have a proper attention span. Moreover, what we have come to know is in a child who is going to cannot sleep properly at night, they can have metabolic disorders, especially obesity. And in adults, it is well known that it can lead to diabetes as well as hypertension. And most often, the most important, a child with a good sleep will always be prevented from infections. We all can understand that if you don't get to sleep properly at night, what happens the next day? Either you are groggy, you are angry, or you cannot do your work properly. Your attention span is less. So all these things affects the sleep. So quality of sleep is as important as the duration. So I'll just go through some of the basics, or what is the importance, or what normally happens. So in an infant of around 4 to 12 months of age, it is important that the child sleeps for around 12 to 16 hours. This is including the naps. Just a minute. So for toddlers, this child should sleep for around 11 to 14 hours. For a preschooler, which is basically to 3 to 6 years old, it is very important that they sleep for 10 to school-going children up to adolescents. It is important that they sleep for around 9 to 12 hours a day. And for teens, it should be around 8 to 10 hours. So what are the most common sleep problems that are encountered by parents when we ask our parents? Most often in the infant age group, it is the multiple night awakenings, which is more common, or it is a delayed bedtime. For toddlers, they say that they have resistance to sleep. They won't go to sleep. They want more time. They want to play more. And sometimes they can have associated snoring, which is obstructive sleep apnea, and they can have restless sleep also. School-going children, the most important thing is the erratic sleep time. They use a sleep phase initiation. They go to bed early, but they cannot fall asleep for a long time. They can also have restless sleeps, moving around here and there while sleeping, moving their limbs. Sometimes they can have snoring, and they could have associated mouth bleeding. So remember, the quality of sleep matters, and as much the quantity of sleep. So sleeping through the night defines the quality in infants. So we should know about the different stages of sleep, and then only we'll be able to understand how sleep really affects our attention, cognition, memory enhancement, everything. So basically, whenever we sleep, we have got there are 4 stages of sleep. The first stage that we call as stage 1, NREM sleep, followed by stage 2, the stage 3, and then the stage 4, the REM sleep, which is the consolidated sleep phase. Usually, if you can remember yourself, if you have seen a baby, or if you have seen a baby growing, usually in the first phase of sleep, the child is usually very awake. Child will be grumpy. Child will be moving here and there. Will be moving his limbs, and then slowly and slowly the baby goes to sleep. And usually, and after once the baby goes to sleep, the baby go into the REM sleep. The REM sleep is the most important phase when there is maximum secretion of the brain hormones, and this is the period when there is brain development as well as brain cognitive enhancement occurs. So usually the sleep cycle lasts for around 1.5 hours to 2 hours in the children, and by around 2 to 2.5 hours, usually the sleep cycle completes, and then the child goes into the second stage of sleep. So awakenings during night, infants are known to have arousals during stages of sleep. So once they complete one phase of sleep, they'll awake, and again they have to go back to the other phase. This is the period when most of these infants will wake up. They'll cry, they'll ask for a feed. Sometimes they have to be taken up, they have to be rocked, and then the baby goes to sleep again. The arousals are minuscule, and one goes back to sleep on their own. So parents may hear whimpering or mild sounds during these arousals, and it may be differentiated from from fully waking up. So certain self-soothing skills also, what we see in most of the children, is the ability of baby to put him or herself to sleep on their own without any resistance. Developing self-soothing is a developmental milestone, and it, however, needs to be assisted and nurtured. And baby should be able to go back to sleep from an arousal during REM sleep, which is natural, and long-term helps in concentrated sleep. So babies begin to sleep long stretches from 4 to 6 months of age, sleep through the night for 8 hours after 6 hours, 6 months of age, and some developmental milestones can interrupt sleep, like a baby who just started crawling, or rolling starts attempting is at the night. By 12 months, all babies are expected to sleep for minimum of 8 hours just through the night without fits. And this is essential for growth and development. So this is why it is important that we start training the children or from the infant stage only, from the age of 6 months, 3 to 6 months of age. The mothers will be taught to develop these sleep hygienes, which I will talk about later, how to develop sleep hygiene and how to develop a proper sleeping pattern in the children. It is very important. Most of the time, whenever a child or a baby comes to our OPDs, we talk about their health, we talk about their illnesses, but we very rarely we take a sleep history. There are certain questions, or I'll just give you a mnemonic to which we can just take a quick history on sleep, and which will guide us for whether the child is sleeping well or whether the child has got any sleep issues. This is relevant for also in children with autistic spectrum disorder. Whenever for our physiotherapists, for our occupational therapists or speech therapists, early intervention therapists, whenever you assess a child, whenever you're assessing the child for the first time, you can always take a short sleep history, which will actually help us or help you to understand the sleep problems that the child is undergoing. So what we take help of is the Beers questionnaire. This is an internationally acclaimed questionnaire which we can take the help of. So for B, it is a bedtime. You take the history of, does my child trouble going to bed or trouble falling asleep? That is, the child doesn't want to go to bed. Child, if you take him to bed, it takes him a long time to go to sleep. So you need to take a history on that. E, for excessively daytime sleeping. Is my child difficult to awaken in the morning? Is my child seems sleepy or groggy during the day? Or is my child seems tired during the day? Secondly, A is for awakening, where does my child awaken during the night and trouble going back to sleep? And is anything else interrupting my child's sleep? Sorry, regularity and duration of sleep. How many hours of sleep does my child does my child needs at this age? And what time does my child go to bed and get up on weekdays as well as on weekends? And does this allow my child to get enough sleep every day? And of course, you need to take history about snoring and mouth breathing, which is very common in children and often these are missed. So does my child snore loudly or every night? And does my child stop breathing or gaps or chokes during sleep? So now we'll talk about sleep problems in children with autistic spectrum disorders. So what are our learning objectives will be? We'll try to identify the prevalence and cause of sleep disturbance in autistic spectrum disorder. We'll discuss about the impact of sleep on social emotional development in autism spectrum disorder, and also we'll try to construct a treatment plan for sleep disturbance in children with ASD. So sleep disturbance in ASD is very common, and many a time, actually, it is the parents who thinks that it could be an inherent part of the disease itself, that this child is not going to sleep or child has got problem in sleeping. So sleep coming for sleep disorders. Poor sleep impacts on the child's health and daytime functioning, as well as a family unit. So sleep disorders are highly treatable. However, evidence-based standards of care for surveillance, evaluation, and treatment of sleep disturbance in the ASD population are greatly needed. So what is the most prevalent sleep disorders that we commonly see in children with ASD? So there are a lot of studies which have been done. There are most common tools for determining the sleep is mostly the tests like polysomnography and the actigraphy, which reports insomnia as one of the most important sleep disorder that is repeatedly difficult to see that occurs despite age-appropriate time and opportunity for sleep and results in daytime functional impairment for the child or family. There could be prolonged time to fall asleep, preference for delayed bedtime. There could be bedtime resistance, sleep anxiety, decreased sleep duration, and increased arousal and awakening. And sometimes there could be early morning awakening. So most of the parents often complain that the child wakes up by around 4:30, 5 o'clock. The child is completely active. The child doesn't want to go to bed. And this is what actually happens in most of the children with ASDs. Since they are of the sensory issues, they'll wake up very early. And this hampers the family unit as well. It hampers the sleep of the parents. And this also results in developmental as well as cognitive impairment in children. So what are the causes of insomnia or sleep disorders in children with ASD? There could be three things basically. One could be a biological reason. There could be certain medical reasons, and there could be behavioral reasons which could be associated with children with could be cause for sleep disorders in children with ASD. Now there are basically two theories which has been studied till now. One is the problem in the circadian clock factor. There's many theories which suggest that the melatonin secretion, which is important for sleep initiation and sleep consolidation, is hampered in children with ASD, and as well as the precursor like tryptophan and serotonin, which is important for melatonin development. These are also disrupted, or these are also non-functioning in children with ASDs. There could be medical issues which could be associated, which could be present in children with ASD. Like children can have GI refluxes. There could be associated seizure disorders. There could be associated obstructive sleep apneas in children with ASD. They can have restless leg syndromes or periodic limb movements, where the child will be just moving his limbs, moving his legs while sleeping, unable to sleep properly at night. And the children can be in multiple drugs. Sometimes they could be in, on antipsychotics. They could be on some anti-seizure medications. All could hamper their sleep initiation as well as sleep consolidation. And sometimes it could be behavioral as well as children who are onto screen times, prolonged screen time, especially screen time before going to bed. Sometimes if there is a TV or an iPad which is there in the bedroom itself, or if the parents are into screens, the TV is running, the lights are on while sleeping, all this can hamper the baby sleep time. So we need to follow the, sometimes they can be exposed to caffeine, chocolates, and all this can affect the children's behavioral problems, and then this can cause sleep disorders in ASDs. And of course, most important is the limited exercise. Most of the children, because of their behavioral issues, they can have limited exercises. So I'll just briefly go through the biology of sleep disturbances and arousal dysregulations. They could be tied together, resulting in anxiety, sensory oversight, responsibility, and there could be associated functional GI problems. And the most important is the dysregulation of the hypothalamic pituitary adrenal hypoaxis occurs in both insomnia and ASD, and in association with daytime stretches. Studies of the autonomic functions provide additional evidence for hyperarousals, and insomnia treatment studies are designed to target hyperarousal, provides an opportunity to measure biological markers of autonomy as well as ASD dysfunctions. So what we see in a child with ASD, basically, the core symptoms mostly are the impaired social interactions, and there is impaired communication. Just like in the picture, the child is in his own world, surrounded by his own thoughts and his own conscience. So sleeps actually affects the development, as well as we can, with a proper sleep, we can actually help in development of social interaction as well as communication. Now, one thing you should think that is sleep is not the only answer to all these problems. If a child with ASD has a proper sleep at night, is relaxed in the morning, once he goes into the early intervention center, if he has slept properly at night, he will be more comfortable. He'll be listening to the therapist properly, and then he'll also communicate, and he'll also try to work out the activities that the therapist provides him, or he'll be more active or more interactive, basically, to take the program that is laid in front of him. But if the child is not sleeping properly at night, he doesn't have couldn't sleep properly at night, the child will come groggy in the morning. He'll have less attention span. He'll be more inactive. Sometimes it might be, in fact, hyperactive. Most often, what we see in children with sleep disorders is the child becomes hyperactive if the child is not sleeping properly, and this could hamper his the early intervention program that he has to undergo. So this can also affect the long-term development or the outcome in a child with ASD. So in treatment of insomnia, there are basically two approaches. One is behavioral approach, and then we have the medical approach. And most of the times, if we follow the behavioral approaches in the children, we'll come out with a positive result. So what it has said that the behavioral treatment of sleep problems in children with intellectual disabilities and challenging daytime behavior reduces parental stress. It increases parents' satisfaction with their own sleep, their child sleeps, and heightens their sense of control and ability to cope with their child sleep. So we can have a children's sleep habit questionnaire where we have around 35 45 item questionnaire where 35 items written in sub skills, where we can ask about the child's bedtime resistance. We can ask about the sleep onset delays, sleep durations, sleep anxieties, night wakings, parasomnias, that is whether there's bruxism, teeth grinding, nocturnal enuresis, child waking up at night, child talking at night. There could be sleep disordered breathing, like the child can have snoring, child can have mouth breathing, child just wakes up while sleeping as if they've been choked. They could be coughing at night. Children, especially children with ASD, with children with allergic rhinitis, they will have nasal block at night, and they will also have sleep disordered breathing at night. And of course, the most important is the daytime sleepiness. It is very important, especially whenever we see a child with ASD. We should always ask for daytime sleepiness as well as the night awakenings. There's one condition which is called as the Smith-Magenis syndrome. In Smith-Magenis syndrome, the children will present with features of ASD, but the most important differential criteria is the sleep patterns. These children are very active at night. They'll not go to bed till early morning, 3 o'clock, 4 o'clock, but in daytime they are mostly sleepy. Whenever they are into the interventional room, they'll sleep, or they will not. They'll be very hyperactive in the morning, and they sleep also in the evening hours. Suppose by 2 o'clock, 3 o'clock, they'll go to sleep. They'll wake up at around 6:30, 7 o'clock, and thereafter they'll not go to sleep till early morning. In these children, we need to identify, because these children, if they are treated medically with drugs for initiating the circadian rhythm of sleep, they do very well. So what are sleep needs? So sleep needs is very important. If you look at this chart, basically, we have got an alert phase as well as a sleepy phase. Especially, we are most active before we go to sleep. That is the most important thing that we all remember. If you think about your own sleep, before you go to bed, you are mostly active. And then slowly and slowly, you go into the sleepy phase, and then you go into the sleep phase. So you have to understand the child's zone where the child will go to bed. As parents, we need to understand, because if you forcefully take him to bed early, the child will not go to sleep. And in fact, that will cause delayed sleep initiation. The child will fight in the bed, child will give more resistance, child will become more inattentive. So, that's why it is important that we understand the child's activities, his alertness, and we should try to able to understand his sleep time. Then only, and if you set the proper timing of sleep, and this will increase the regularity of sleep, and it will also improve the wake time in the morning. So for components of successful sleep, very important that we develop certain habits, what we call as sleep hygienes. There has to be particular daytime habits. Sleep environment is very important, evening habits, and bedtime routines. So we need to sleep coach the children. So benefits which are noted with sleep routine and coaching is shorter sleep onset latency. There's decreased wakefulness after sleep onset. There's increased sleep consolidation, and there's significant improved noted in maternal mood state as well. And significant changes are seen in parental perception of sleep issues. So primary steps of sleep coaching include, we need to set up a fixed bedtime. We need to establish a sleep routine, reduce close sleeping, which is of course very difficult in our Indian setting, because it's a part of our social taboos, and we still see that most of the children up to around adolescence, they still close sleep with their parents. And safe sleep practices, which is very important to establish and to follow from the very beginning. So this is one thing that we need to inculcate into our parents, so that they follow this routine. And whenever we follow this routine, we need to either tell the child, or we can show them the picture that after dinner, we are going to wear the night dresses, you're going to put on the night pajamas, then you're going to the bathroom, you're going to clean up yourself, wash your face, brush your teeth, and after that, either one of the parents is going to tell him a story. And as you are telling him the story, you need to tell him that it's time to go to bed now. After say 5 minutes of storytelling, you know, now after that, we have to go to sleep. After 10 minutes, this is the time, I'm going to tell them story for the last time. You need to go to bed now. We're going to switch off the lights now. We're going to sleep now. So this is how you develop the routine in a child. And most of the children with sensory issues, if you show them pictures, they usually identify the pictures very well, and then they understand that after each stage what they need to do. So if you develop these skills in the child, especially in the children with autistic spectrum disorder, the sleep time becomes easier. So since children will have limited verbal skills, you can also put up some photos. Like you can put toilet paper, a soap, shampoo, a brush, a storybook, which can be a child can easily see, and you can put it in front of the bed so that the child can understand. And this gives a cues into the environment that this is a time that you go to bed, and after this, each step, the child gets himself ready to sleep. So there are certain pharmacological treatments which are available. Of this, of course, most of these drugs which are available in the market are not FDA approved, although they are used in the market and they are being widely used. The most common drug that has been used is the melatonin, which is available. It is available even in our state also. And sometimes these children with autistic spectrum disorder, which we have problems with sleeping or with delayed sleep onset or with unable to maintain sleep at night, the children do very well when they are given these drugs. So whenever possible, choose a medication that will treat a comorbidity. If there's epilepsy, anxiety, or mood disorders, we always start with a very low dose. And for primary, we don't have any FDA-approved drug. And variety of other anti-epileptic drugs, atypical antipsychotics, and antipsychotics are also used for off-label to treat children with insomnia. Most common drug that is antipsychotic that is used is the risperidone. So melatonin can be used in special children, especially children with ADSD, Engelmann syndrome, Smith-Magenis syndrome, Rett syndrome, tuberous sclerosis, and intellectual disabilities. So in summary, sleep disturbances is common in children with ASD and is associated with social and emotional functioning. Sleep disturbances is also very highly treatable, and identification and treatment of sleep disorders in children can contribute to improved functioning in child and family. So additional areas for research include how to best deliver behavioral sleep education, how to best select the medication in sleep, and how to combine treatment modalities. So if the child is sleeping well, it also helps the parents to sleep well, and happy parents and happy family makes the doctors to sleep well. Thank you.
Thank you.
Thank you, Dr. Partha. Nicely explained. I think question I will take later on.
We can take the discussion now itself, or maybe if there are a few questions, anybody has put up any questions?
Hello, Pritasmita, this is Manishi. Can I?
Yes, please.
Yeah. Good evening, Dr. Patu. A very insightful talk on a very important topic that regulates our day. A few, just like rightly said by you, when we assess a child with ASD or ADHD, the very common complaint that we get to hear from the parents is, my child doesn't sleep, and it is affecting even our daily routine and our quality of life. A question by what time should even a neurotypical child should be having their dinner, and what kind of food that we should be avoiding at night before they go to sleep?
See, there are two things basically. When I was discussing about the causes for sleep disorders in children, there are two things. One is behavioral, and the other one is the other products. Like as you have said about the diet, of course, the caffeine-containing diets. If you have taken coffees, teas, chocolates, and all high sugar-containing things, these things are going to affect the sleep. We need to, most important thing is that we need to develop a sleep hygiene. Whenever you meet a parent, our complaint that child doesn't go to sleep up to 1 o'clock, 2 o'clock at night. That is the most common complaint that we most often hear. So what do you counsel them? You cannot make them say that you try to make them baby sleep by 8 o'clock in the morning. If your child is sleeping late, the most important thing that we need to answer is, suppose the child is sleeping late around 1 o'clock at night. So the best possible answer to parents is that try to make him sleep by 12:30 at midnight. If he's sleeping at 12:30, next week try to make him sleep around 12 o'clock at night. If he's sleeping at 12 o'clock, so slowly you try to, every half an hour, you try to bring down, so that the child can sleep by around 8:30, 9 o'clock. Ideally, if you see a child needs, for a 3 to 6 year old, which is our most commonest group of people with child, so for them, the ideal sleep time is around 10 to 12 hours at night. So they has to sleep by around 8 to 9 o'clock at night, so that they wake up by around, again, 7:30, 8 o'clock in the morning. then only they'll have around 12 hours of sleep. So ideally, we should try to make them sleep by around 8:30, 9 o'clock. But if the child is already sleeping late and he's not been sleep coached earlier, you need to gradually decrease the sleep time from his initiation of sleep. Then only the child will comply and the child will take the routine, accept the routine. Otherwise, if you straight away ask him to sleep at 8 o'clock, the child will revolt, he will not sleep, and it will be a failure. Secondly, about the other problems, like sometimes the child wakes up at night. Most of the time, what happens if the child wakes up at night, the mother tries to feed the child. They give a bottle feeding at night. Somebody will pick up the child, somebody will rock the child. These things needs to be avoided. And most important again, co-sleeping has to be avoided. The children, they need to sleep on their own, and if possible, they need to be kept in a separate room. Again, one new thing that has come out is the darkness. The room should be proper. It should be complete dark. In dark areas, only the child can have normal melatonin secretion. If there's light, it always hampers the melatonin secretion. One important thing that I learned recently is that the wearing of night dresses in children, especially children with ADHD, since these are children with sensory problems, whenever you put them the night dresses, it is very important that you put night dresses which are snugly fitted, tightly fitted. If you put a tightly fitted night dress in them, they comply very well, and then they go to sleep early. It says what the researchers have said. So you can also give them advices.
Thank you. And what about afternoon naps? Should it be restricted to? Should it be restricted to only 45 minutes?
We don't count afternoon naps. But again, afternoon naps doesn't mean that the child sleeps from 3 o'clock till 6 o'clock, 7 o'clock. Afternoon naps should be around half an hour to 1 hour, not more than that.
Thank you. Thank you so very much.
Thank you so much.
Partha sir, this is Ravinder Singh, occupational therapist from Assam Rehabilitation Center, sir.
Hello, Ravinder.
Sir, I have a question. As you are saying that this child have problem, they sleep at night at 1 o'clock or 2 o'clock. They need proper sleeping environment, and you were also discussing about the food habits that they do. They or mothers are feeding the child, but I have some cases that have food habits also. Their food habit is also very bad. They do not take feedings, milk or any type of food, and along with that, their behavioral is something like anything. You cannot control them. They become aggressive day by day. They are getting aggressive day by day, and they have tried everything from medicine to homeo, and we have also modified their sensory room type. We have made pressure sickness room, dark room concepts, but sometimes the problem still persists. So it is very hectic for us also, and for the parents, no doubtly, to console them and to track them to the right path. How can we deal with that if the child has feeding issues along with sleeping issues plus behavioral issues along with it, and medicine is not working on it?
Yeah, very good question, actually, Ravinder. See, this is very common thing that we encounter also. See, children with behavioral issues, sensory issues, they'll always have problems with feeding as well. Basically, either they will be very fussy eaters, they'll not be eating properly. And since they doesn't sleep properly at night, again, they will have inattention, they'll be hyperactive, all these things can happen. Especially in a girl child, if you're seeing certain symptoms.
Yes, I'm looking after a girl child. Actually, I'm talking about a girl child only, sir.
If it's a girl child, always think about Rett syndrome. Children with Rett syndrome, they are very hyperactive. They'll just listen to anything. They'll not eat. They will be always irritable, crying all the time. It's very difficult to train them. And these are children with genetical problems. They've got MCP, some gene defects, which are resulting in these serotonin and tryptophan difficulties in the brain. Children, this is what we commonly see in children with Rett syndrome, especially in girl child. For boys, children with Asperger's, most often, they are also very hyperactive, inattentive. So we need to identify the children. Of course, sleep coaching again helps in the children. You need to have a proper environment, proper sleep time. Then again, you need to look at other deficiencies. these children have iron deficiency associated with them. Children with iron deficiencies, most commonly what we see, children with iron deficiency in the brains. So there are a lot of studies. They say that the children have got low iron in their brain. That's why they remain very hyperactive. The children, they will not respond to normal oral iron therapies. They might require venous iron therapies to bring down their hyperactivity or their inattentiveness. So we need to look at the whole spectrum. Basically, it's very difficult to give a one-point solution to them. And I think if you look at the history, we look at the things, and if it's a girl child, I think you need to rule out Rett syndrome in the child.
So basically, sir, we have to correct whether with ASD it's Rets or not, especially in girls.
Yes.
Isn't it?
Like
Okay.
Girl child. Common.
Okay, sir. Thank you so much, sir.
Yeah.
I think we can move to the next talk.
Yeah, Pratishmita, let's start the next second talk by yourself.
Yes, sir. Okay. Just share my screen. Just a minute. All right. Am I audible?
Yeah. It's audible now.
All right. I'll start with my topic. My topic today is communication in nonverbal children. So before that, I would like to welcome everybody for this webinar. Everybody has taken out their time on this Sunday and have joined us. We are very grateful. And so let's make this neurodiversity an acceptance in the society. And with that from the professionals and the parents, let's embrace this neurodiversity. So with that, let me start with this communication in nonverbal children. So we always talk about the communication generally, how to communicate, how to talk about the verb, like making it verbal, like making it to speak. So a lot of time we see children with ASD, they mainly have the problem of being nonverbal. Like 13% of children with ASD are nonverbal throughout their life. Studies shows that earlier it was like more, but then the study says that like if we start up with early intervention, a lot of time we can see the verbal being verbal or being with speech and language is seen, but still a lot, even if we start with early intervention, even by 2 years of age and 1.5 years of age also, there are children who are nonverbal in like throughout their life. So now is it being nonverbal, or is it not having a speech is hampering them, or is it them asking not to communicate with the society? So it's not like that. We always have a mode to communicate with the society. With socially, we can be acceptable. We can have our own thoughts and ideas communicated. So, so what is communication basically means? Communication means the process of exchange of ideas, thoughts, and emotions. So whenever we need something, whenever we need to tell something, we do communicate. We basically start up with saying our basic needs, and then we generally start up moving with our own thoughts and with our own emotions, with our own ideas. We share all this, and then it comes up as a communication. So now communication again have to be effective. Like if I'm talking in a particular language, it should be a socially acceptable language. If I speak in Tamil here in Assam, of course half of the people won't understand. I mean, maximum of the people won't understand until unless there is somebody who has learned Tamil. So similar way, if I use a certain kind of gesture, even using a gesture or using a verbal speech is a communication. We are communicating with a person. So that have to be socially acceptable for the particular group of people. So it can be gestural, it can be verbal, it can be symbolic. Also, we can use alternative augmentative communication. So this is what I'm going to talk today about alternative augmentative communication. Alternative augmentative communication is one of my very area of specialization. I like to say people, if you are not getting verbal output, please go for alternative augmentative communication. So before moving on to it, let's know what is alternative augmentative communication. It is a type of communication which can compensate, or basically we use it maybe temporarily or maybe permanently. Like it can be an alternate mode of communication, or we can also use some augmentation, like the person is maybe using a verbal speech, maybe a sound. Along with that, we can augment a other kind of speech or other kind of modality. So just before moving into the whole part of alternative augmentative communication, let's see a small clip.
Now, Professor Hawking, in the very last paragraph, freedom universe in broad principle to everyone and not just to a few scientists. And when that happens, all of us will be able to start discussing the why. It would be the ultimate triumph of human reason, for then we would know the mind of God. Do you think that God can intervene in the universe as he wants, or is God too bound by the laws of science?
The question of whether God is bound by the laws of science is a bit like the question, can God make a stone that is so heavy that he cannot lift it? I don't think it is very useful to speculate on what God might or might not be able to do. Rather, we should examine what he actually does with the universe we live in. All our observations suggest that it operates according to well-defined laws. These laws may have been ordained by God, but it seems that...
Okay, so we saw here Dr. Hawkins, Dr. Stephen Hawkins, we all know. He is nonverbal. He had cerebral palsy, and that's why he was nonverbal. But he used his thoughts and ideas using a machine. He could talk to the world. He could share his ideas. He could share his theories with the world using a machine. So this is what he is using, an alternate way of communication. Let's not go into the bioengineering of the machine, how it is using. The machine is using his senses, eye tracking, and all. It's a very high-tech alternative augmentative communication device. So there are lots of devices we can use to do alternative communication. So this was one which Dr. Hawkins was using. So this is called the alternative mode of communication. Or maybe if we are using a sign language, that is also an alternative mode of communication. So next here we see a girl. If I now ask you all, what is this girl doing? Everybody would say definitely smiling or laughing. But I'll say no, she's saying yes. Everybody will say no, we didn't hear she's saying yes. We can just see she's making a face and she's saying, maybe she's laughing. She's not saying yes. Or maybe you cannot read her. So then I'll show you another picture. So this boy, I'll say now, what is he saying? Definitely a lot of us will say, oh yes, the child is saying yes. So this is how we understood, because this kind of gesture is a socially acceptable gesture for us for saying a yes, and we could say that the child is saying yes. So here he is augmentating his speech yes. This way, okay? So he is using a gesture, and this is called augmentation with his speech or whatever sound he is using. Along with that, he is using a gesture. That is what augmentation. So we can always, if a child is not speaking or if a child is using a less of verbal speech, we can always augment, or we can always use an alternate mode for communication. So what means is we have to communicate to the other person. Again, a lot of time we have seen I'll just give an example. When a child comes to a speech pathologist or a speech therapist, like they go for a lot of time, like, you speak this, you say this. So I'll tell you a story where the child has been taught the word bathroom, but the child don't have a proper pronunciation. The child can say use the word so, this word he can say properly, but the child, he have been taught the word bathroom. So after the child was taught the word bathroom, he went to a place and there were many people. So his parents weren't there. He says the word bathroom is athum. Okay, so this is how he's been saying. And then his parents weren't there nearby and his aunt was there. Then he wanted to go to the toilet and he said athum. So the aunt didn't understand. So then the child had to soil up there and the situation became bad. So how to avoid this kind of situation? Maybe we can tell the child with some gesture, or maybe we could have just taught the child, instead of bathroom, instead of such a tough word, we could have just said the word so, which could have been understood by the aunt even. So these are the things we have to keep in mind, even by the parents. When you are teaching your child, when you are telling your child to say few words, if the child is having difficulty, go for an effective communication. Making a communication, more than making just a communication, the effective communication is important. So so there are different types of AACs. This is one, like this is a, we have board books. Okay, so now when I tell parents, let's go for AAC, let's start up with alternative augmentative communication. If the child is not speaking, why to wait? They're like, no, the child won't start. Like, let's not start up with any AAC. Let the child speak. That's okay. Let the child speak. But what is important? The child has to communicate with you. The child needs to tell what he needs. So there are different types of AACs. Like we can make a board books. What the child wants, will make the child's dish, like what are the interested things he wants to eat. We can put the pictures. The child might point up pictures. The child might say the vegetables. In that way, we can keep. So there are the devices which we can use, the apps. There are a lot of apps which can be used as an AAC, alternative communication device. There are buzzers we can use for different colors. We can make different words or different expressions we can use. If the child has put red, he means that he want to go to washroom. If he has buzzed up the yellow, he is like he want to have food. So this kind of things we can also provide. Even in children with hard of hearing, a lot of time what we can do, rather than like using an alarm, rather than using an alarm which has a sound, we can keep something with vibration. So that is a mode of alternative communication. The child is using a AAC. The child can use a keychain. So if the child went out, he can have this chain and he can show in the shops. And also these are the way we can modulate for a person to go for AAC. We can use eye trackers. There are a lot of eye trackers we can use. So these eye trackers, the child can use using whatever the particular thing they want. Then applications, lots of applications are available. So I would show one of the application. Okay, so I would show you Avaz, the app Avaz, how to use this Avaz app for communication.
Advanced. Play. Let's play. Indoor. Lego. Let's play a Lego. Clear. Quick. I can't find the picture. I need help. I am not well. Delete. Delete. Home. Basic. Play. Music.
So basically using such apps, it helps a child to communicate so much better that we can see a lot of time, we can see miracles. Like we saw a child who wasn't even saying anything. As soon as we started off with the app, he started saying so much. He started saying a lot of things he wanted to say. He wanted to go out. He wanted to play outside. He wanted to have a cycle. He never said us all those things. So we can actually see magic when we give an alternative communication to a child, especially in children with autism. They have so much thing to say. They have so much inside them. They can actually say you out so many things. Just the thing is, you need to accept it. You need to say that, okay, we are ready to use an app, or we are ready to use an alternative way of communication. Let's not just stick onto the verbal mode of communication. And that's okay. And a lot of time people think that if we start up with ours, so or if we start up with any kind of alternative communication, there might be a hindrance in speech, but that is not true. So who can teach or how can we learn AAC? Alternative augmentative communication is actually been taught by a speech language pathologist, also a AAC trained special educators, and by specially parents. And how it goes on, it have to be in modeling, like how we speak, right? How we speak, how we talk, the similar way we'll have to model up using AAC. So there are a lot of myths about using AAC. So whenever we say, like, let's start up using AAC, the first thing parents will say, no, let's not use, because my child will not going to speak ever. But that's not true. We have seen, a lot of research have shown, as soon as we start using AAC, the verbal communication even starts improving. And that is there. We have seen in our practice only, a lot of time when we start out with AAC, they start out with the verbal communication also. Alternative communication is, again, I am saying, it is just an alternate way. It's not the permanent, or we are not keeping that only mode of communication. Yeah, later on, if the child grows up and we see, yeah, the child is not using any kind of verbal input and the child is more happy with the AAC mode, then let's give the child. If he is using that or if she is using that, let's give it to the child. Like, they are comfortable using that, right? That is what we want. We don't want the child to come and be like us. We want the child to be comfortable, the child to communicate. Then people think that, okay, to use AAC, the child have to have a lot of motor stability. No. The child don't even have to have a proper IQ. That it's not necessary that child have to have a very good IQ to understand what are the things. It's not like that. The child, a lot of people say is that, no, the child have to understand all the verbal language. It's not even like that. And people say is that, no, it's not socially acceptable. Let's start using it, and then it will become socially acceptable. If you and I start using it, and you and I tell our children, like, let's start using this, maybe we will start making it socially acceptable. So again, what happens, it's when we say, like, how to use AAC, just a breath, the child alive is enough to use AAC. So we don't have to have a very good motor stability or have a very good IQ to use an alternative way of communication. And how would alternative augmentative communication help? It will, of course, reduce the frustration in the child. A lot of time they want to say so many things, they cannot even express, they cannot even know how to use it. We just need to help them, show the mode, how you can communicate with us, and you just see a miracle. Then it will, of course, improve the quality of life, with the family, then with the child. Then they can actually communicate their needs. It will improve social behaviors. It will also improve their understanding and expressive language. Okay, so there is one small video I just want to share, because how to communicate or how to model, like how we speech, how we model speech, and how we talk, and how the child learns speaking by seeing at us, right? So if you are a parent who is observing today, so, or if you're any of the rehabilitationist or doctor, so I would like to say that start using, if the child is using an app or alternative mode of communication, even you start using that with the child, then they will model or they will learn from it. I'll just play this video as what it says is whenever the child is using the AAC, that's the other person, the communication partner should also use the AAC for the child. So with this, I would like to end. This is my references, and thank you. Let's accept this neurodiversity, and also let's accept AAC as a parent, as a professional, and also as the society. Thank you.
Thanks, Pratishmita. Nice talk. I remember I passed my master's in 1991, and that time AAC was very primitive stage, and we are taught AAC, you know. And when I came back to Guwahati in 1997, I started working with CP Child and Shishu Sharati. Then when I visited there, I found few children were not able to speak, but their communication skills are very good. Then with the help of teachers, I made some communication board by cutting the pictures, by drawing pictures, and that works wonder with the CP child. You know, they could able to communicate after few trainings. You know, and AAC do work wonderful for the children. Thanks, Vidishmita. Now, any question? You can take question.
I think there's a question from Lakshmi. She has asked that if a child is normal hearing and not able to speak, in this, what to do? We'll start directly AC or motherish words. Child is 3 years old, autism case. Actually, what is told, whenever the child comes to you, if it's always better to start up with AAC and along with your traditional speech and language therapy, because you start up with AAC, you see the child has started picking up a lot of words. I mean, the child has started communications. The child will start up with communications, and then you can actually go along with that your traditional speech and language therapy. And you will see the child has started up keeping up. If the child is verbal, you will see the child has started picking up verbal. And slowly you can take off the AC and you can go to the verbal mode.
And I just add it, you know, if you add AAC, the child will have a good development, vocabulary development, you know, and this concept development is very good. Once the child concept development starts, the child will, if the child is other capacities are all right, then child will start speaking. And now slowly you can withdraw AAC, and AAC and speech can go simultaneously.
Yes, yes. So basically abroad, it is always done in that way. As soon as they come for speech therapy, they start up along with a speech therapy, traditional speech therapy, they go with AAC. The AAC is always taken by the trained AAC trainer. And then, it can go hand to hand actually. Any other questions I need to take, or we can go to the next talk? What are the language, Dr. Rajkumar Paul has asked, what are the language programs we use? Language programs, is in, sir, can you please tell it properly?
I'll just tell you. I think Dr. Rajkumar is talking about language acquisition device. I think he's talking about LAD, language acquisition device, that is in the brain, you know, and once you stimulate the brain with early stimulation, the LAD blooms and the child starts speaking, you know, they're developing language. That is, I think, Chomskyan theory you are talking about, Dr. Rajkumar?
Yes, sir. I wanted to just ask about the language programs, like the mocktail programs and all. Those are used for non-verbal children. Na? What Pratishmita is using here, I just wanted to know.
Yeah, there are different programs are used, you know, that she is talking about hours, no? This is one of them.
Yeah, there are different programs and different apps. If you're asking about the apps, there is the app called Jello. There is basically used in India are two, like not two, there are a few more, but what is popularly used are Jello and Avaz. And abroad in US and UK, there are a lot many others. Here we can use Megathon language. There is something called Megathon language. And there are certain, what I use here in my sessions are like board books. I make the board books for child. So those are low aided. So if the child can, the parents can go for an, for a tab, so we can make the child go for the apps, because these apps and all are like, we have to take monthly subscriptions. So those Jello and Avaz is what we are
And I am forgetting one program in US that is very popular, and they use for AS, that is for the children also, as well as for the brain injured, for the your stroke patients, and even for the patients who had head injury, they start using that program, forgetting the name of the program, extensively used in US, developed by one of the Indians. Actually, they have developed, and it is extensively used in US for the brain injured, even for the children, and even for the your aphasics. I'm forgetting the name.
Yeah, it's Macathon. Macathon, yeah, Macathon is used.
Macathon is not Macathon. There is another one. I forgot the name. I'll tell you, Rajkumar, sometime.
Okay, so any other questions? Suggest more ACF names. So that's a Jello or Avaz you can go for. So we can move on to the next talk, I guess. Yes.
Yeah, Dr. Manshi, you can move on to the next talk.
Dr. Ravindra Singh has raised his hand. I think he wants to say something. Yes, sir, please.
Yeah.
Sir, you have a question?
Hear me?
Hello?
Ma'am, can you hear me?
Yeah, now I can hear you. Yes.
Acha. These apps you are talking about, they will be in English language.
Yes.
How to deal with, suppose we in northeastern states, we have very diversified language culture. You were talking about US and all. There are simple one language formula that has been used. In Delhi, you can go, they basically use Hindi and English. So how to cope up with those language, because we as a clinicians or therapists have to deal with people coming from Manipur, Nagaland, Bengali speaking, Assamese speaking, Hindi speaking, tribals are there. So how to deal with that through this app?
Extremely good question, sir. So what happened, this Avaz app, so Avaz app has 10 languages. It's in Marathi, 10 regional languages, but we can use Assamese using the Google Translator. In Avaz there is the option to use Google Translator, so we can use Google Translator over there. We can use our different regional language whichever are there in the Google, so that can be used as well for Avaz. I'm not very much sure about the Jello app and other apps. I know about Avaz, so that's how it is. It has helped us a lot in keeping the children who knows the languages. But the thing is, again, what happens if you want to go for the languages, because there are symbols. So with the symbols, mainly the nouns or the what we call the fringe words. The fringe words are more in the English, and then the other the quick phrases, if we want to make, like I want to go to toilet, I want to go to bed. So those words we can actually use Google translators, and we can keep. And even in Avaz, what is there, you can just we have this this one. Yeah, the option of keeping our own speech or own language. Suppose if you make a icon, so that icon will have a particular picture. Suppose the icon has a picture of a ball, and you can make the child say ami khelibo jao bula. Ami khelibo jao bula. We can make a sentence, and we can record it, and we can keep with this symbol of ball. So as soon as the child wants to talk to somebody, he can just put the symbol in the quick phrases. The child can go to the ball, and then he can say ami, and he can the app will say out ami khelibo jao bula. So there are options like that. So that's pretty lucid to use, and it's very versatile. We can use that way.
Do we have in Assamese language that one?
Yes. I mean, see, for Assamese language, it is not there. It's not a developed app is not there in Assamese language, but we can use in Google Translator, and also we can use the recorded voice.
Okay. Thank you so much, ma'am. And it was a very nice presentation.
Thank you so much. Any other questions? We'll move on to the next talk. This was sir.
Yeah, let's move to next talk. Dr. Manshi. She'll talk about.
Yes,
Yeah.
hello everyone. Yes, so I'll be talking about sensory processing disorder. So pardon me for using two systems. So to avoid the confusion, I think I should switch off the video. Thank you for joining us on such festive evening today, and hope you all had a very good celebration of Rongali Bihu. Let me share my screen. Just give me a minute. I'm having a bit technical issues with my laptop today. Hope it's visible now.
Yeah, it's audible. Yeah.
Okay, thank you everyone. So my topic today is sensory processing disorder. I am Manashi. I am occupational therapist in Pratiksha Hospital, and I'm also visiting consultant occupational therapist in Astitwa Hatikau. So let's start by sharing some of the real life practical examples from our clinical situation. Why it is important to discuss about sensory processing disorder, because all these cases that I'm going to mention here that appear on your screen are cases, real life cases. So Master R covers his ears when mom is blending the blender or using a hair dryer. Miss S refuses to touch food or paint or crayon or Play-Doh. They are all cases of autism, and they are showing some of the sensory defensive or sensory processing issues. Master L doesn't sit on chair or even on the floor, and he keeps climbing the window or enjoy falling on ground for his play. And his mom says he doesn't feel pain like other children, but he doesn't let me cut his hairs or nails. Master B cannot jump or catch a ball, although he is 4 years old, but he started walking before 1 year of age itself. And Master R refuses to play on any play equipment, so he will keep on running in the playground, but he doesn't want to get onto any playground equipment. Master A keeps on bumping into things as if he is unaware of the environment. He keeps hurting himself, but he is not aware where he gets hurt. Master Y only seems only sleeps when his mom rubs his belly or there is some instrumental music playing in the background, so he has difficulty falling asleep. Master D doesn't chew food or eats only limited staple food, but he puts on everything in reach in his mouth. So these are the common examples that we see. Like I think most of us who is in this area might be having similar examples in their work life. So that is why I choose the topic of sensory processing disorder in autism, because it's like as we move on to the next slide, sensory processing disorder actually is not uncommon. A study shows that 3/4 of the children with autism have signs of sensory processing disorder. But I want to make clear that sensory processing disorder itself is not a diagnosis. Usually it exists commonly with autism. Sometimes it may exist separately as well. So as we all can have some of the sensory difficulty, like for example, we may have sensory preferences or have some difficulty with sensory processing, but it is considered a sensory processing disorder only when the child is on extreme ends of the continuum, demonstrating disruptive, unpredictable fluctuation, which is significantly impacting the developmental skills or everyday functioning. Like, for example, he is not eating certain kind of foods, he is very hyperactive, that he is not able to sit down, he is not able to fall asleep, he is not wearing certain clothes, and he avoids certain kind of grooming and all. So that is when we diagnose as a sensory processing disorder. However, it's not a formal medical diagnosis of its own. So to understand about sensory processing disorder, we should go a little bit to the history of sensory integration. Sensory integration, the pioneer of sensory integration is Anna Jean Iris. She was alive between 1920 to 1988, and she began developing the theory and associated intervention techniques for sensory integration in 1950s, based on principles of neuroscience, biology, psychology, and education. So basically, sensory integration is it's like interplay. It's like a circular process. It's an interplay between brain behavior stimulation. So the brain takes in sensory intake, then it registers the input, then it plans and organize the behavior, then it shows the adaptive behavior, like for example, catching a ball or something, and then that feedback is stored. And then again, when the next sensory intake comes in, we remember from the feedback, take the new sensory intake, and then we do registration, and this whole cycle goes on and on. Okay, so can we take a minute to look at this picture and then see like how many sensory system or how many senses the kids are using in this playground? Any volunteer? Any volunteer who want to mention certain senses or feel like certain sensory systems are used in this playground setup where multiple kids are playing together? Okay, so we can see they are climbing up. So they are using the proprioceptive sense from the body. They are balancing. So they are using the movement sense of the body. Then they are talking to each other. So they are listening. They're using their vision. They are touching items. So they are using multiple sensory input at the same time. So when the body is not able to process any of this information, what happens is ultimately the output will be not as we expect it to be. So let's talk about the senses. So as we all know, there are 5 senses in the body: vision, smell, taste, hearing, touch. And apart from these 5 senses, there are 2 more important senses which lets our body to function adequately. Are we okay? Am I going very fast?
No, it's okay.
So let's talk about proprioception. So this is the most vital and most significant sense that helps us function in our day-to-day life. So proprioception refers to sensory information telling us about our own movement or body position. We can also say it as pressure sense and joint sense. It provides intake that helps integrate touch and movement sensation. So it itself is a sense, but it also helps in integrating to other important sensation. That is why it plays a very major interplay. Receptors for the proprioceptive sense are in the muscle, joints, ligaments, tendons, and connective tissue. And the stimuli for the receptors are movement and gravity. So as we see in this picture, like the children are playing all different kind of play equipment, or they are performing different activities. So the major key point here is they are integrating their movement and touch sensation or other sensation like even visual, auditory, everything all together with proprioception. So this is one of the major sense that we would be looking into when we are talking about sensory processing disorder or management. And next, very important is vestibular sense and about vestibular system. So vestibular system tells us where our head or body is in relation to the surface of the earth. So whether our body is straight or how our body is tilted backwards or forward, whether we are standing straight and everything will be known from the vestibular sense itself. This system takes in sensory messages about balance and movement from the neck, eyes, and body, as I mentioned just now, sends these messages to the central nervous system for processing, and then helps generate muscle tone that allows us to move smoothly and efficiently. Then for the vestibular system to work perfectly, there is a very smooth functioning of vestibular apparatus is needed. So vestibular apparatus, this is basically about anatomy. So I am not going to tell in very detail about vestibular apparatus. Basically, it has all these hair bundles, which lets us know about the vertical alignment of the body, vertical alignment of the head. And again, there are semicircular canals, which helps us about the rotary movement that we are having. Or sometimes when the system doesn't work properly, the body might seek lots of movement because the system is not registering enough. Or sometimes even the slightest amount of head movement can be very nauseating. And so this is also when we do sensory integration therapy, basically we try to integrate multiple vestibular inputs, and most of our activities are directed towards vestibular apparatus, correcting the functions of vestibular apparatus. So sensory integration and sensory integration dysfunction. So sensory integration is a neurological process, as I mentioned. So it's process of organizing information we get from our bodies and the world around us in our daily life. So it takes place in central nervous system, which consists of countless neurons, spinal cord, and the head and the brain. So pen, that is the brain, obviously. And as the founder of sensory integration therapy said, the brain must select, enhance. So sometimes we need to enhance, inhibit, control. Control means inhibit means we need to suppress some of the sensations. Compare, so compare between before, after, and what is going to happen next, and associate the sensory information with flexible, countlessly changing pattern. In the other words, the brain must integrate it. So this is the whole process of sensory integration. Okay, so brain is basically a sensory processing machine. In simple word, brain also works as a sensory filter. Like for example, right now when we are sitting, we must be having lots of diversions in front of us. Somebody might be calling over phone, or somebody is working at house, or those parents who are listening, your children might be crying, or your husband is asking something, or your wife is asking something, but we are filtering all this information away, and then we are only focusing on this webinar right now. So this is how the brain works as a filter. But for children with sensory integration dysfunction or sensory processing disorder, somehow they are not able to filter out this information, and there is a mismatch that happens between the stimulus and the response. So what is sensory processing disorder? The sensory integration dysfunction, or commonly called as sensory processing disorder, is an inability to process information received through different senses, which are the 7 senses. Behavior problems are almost always present with a person with sensory integration dysfunction. Self-regulation problems also occur. So self-regulation is the ability to control one's activity level and state of alertness. Like for example, if somebody of you is hungry right now, you're still waiting, you're regulating yourself so that the talk ends, and then you can go and have a snack break. So that is self-regulation. So what happens is when we are not able to filter out unnecessary information, so we are having difficulty in even regulating ourselves, because all of these inputs, or even our interoreceptor, our exteroreceptor, everything is working all together. So it becomes very overwhelming, and eventually we are not able to regulate ourselves. The vestibular, tactile, and proprioceptive senses are the fundamental, as I mentioned. This actually, there is interplay of all these 3 senses in all of our activities of daily living, our learning, our fun activities, even for sleeping as well. There is a constant interplay between vestibular, tactile, and proprioceptive senses. Sometimes the brain inhibits certain things and enhance certain things. Like for example, when we are touching, we are not thinking about the weight of the sand. That is the proprioceptive part. So we are thinking about the texture of the sand. And sometimes when we are walking, we are not thinking about the movement part of it. We are thinking, like for example, crossing a puddle, or crossing an obstacle. So brain is filtering out that we are walking. So but the brain is giving more input to the joints so that we can lift our legs adequately and walk appropriately without falling. Okay. So by far, we have discussed only about the basic of the sensory processing disorder. So now we are going into a bit more detail. So the whole process of sensory integration or sensory processing can be divided into 3 parts. So for the first part will be sensory registration, where the brain filters out the stimuli or enhances the stimuli. Basically, the brain filters out what is needed right now, and then ignores all the other information that the brain is receiving. Sensory modulation is more enhancing and inhibiting. That happens like the brain plays like a balancing, fine tuning, and sensory integration is the response. Like for example, I'm breaking like one of these activities from here, like let's take an example of catching a ball. So the sensory registration part will be filtering out stimuli. So I am ignoring all other elements in the environment. For example, if there is a car running by the road, there is somebody honking, or somebody asking somebody else something. So I am not listening to that. I am filtering out the stimuli. So I'm looking at the ball. Sensory modulation will be I'm arranging the body. I remember how the weight of the ball is supposed to be, and then I arrange my body accordingly. Sensory integration is I am able to catch the ball appropriately. So sensory integration is basically most the higher level. So if we are talking about the hierarchy, sensory registration will be the baseline. Sensory modulation will be the main functioning of the brain here, and then sensory integration is the output or the response. So to make it more interesting, will there be a volunteer who will be willing to talk about any of this activity, or can we skip to the next? Okay, I'll wait for 5 counts. Okay, so let's move on to the next slide. So basically all of the, let me take one more example, like for example, the girl skipping the road. I want to highlight this example because she is, again, when she is filtering out, she is not filtering out the auditory, and she is not filtering out the visual. At the same time, she is using vestibular proprioceptive. So the brain is filtering at multiple level, multiple sensation, and modulating at multiple level, multiple sensation. At last, she is able to jump and cross over the road every time they are doing this, like counting, and they are jumping on the rope. Okay, so so this is in a nutshell about sensory processing disorder, like background of it. So how do we find out when a client comes to us? So in Pratiksha, what we do is we screen all the clients coming to us via a general occupational therapy assessment. Some of us who has the license to do, we also do sensory profile or sensory profile too. Right now we are not doing sensory processing measure, but that is also a very good tool to assess for the sensory deficits and sensory needs. And most important is interview observation specific to chief complaint highlighted by early intervention colleagues. Like for example, my SLP colleagues say like the child is like regarding the feeding issues, they have a particular issue. So I generally don't see feeding in my clinic, but if there is a complaint from the SLP that we are having this difficulty, like suck, swallow, breathe or something like that, so we try to assess specific to that complaint. And there is a homegrown SI clinical observation checklist, which is adapted from Anna Blanche 2002, based on sensory integration theory. So we try to score the behavior of the child. So it's like not significant like that. We try to score, and we try to, when we're doing a reassessment, we try to rescore it so that we can see whether the child has progressed from the intervention or not. The common issues that are identified via these assessments are sensory registration, because that is the baseline, sensory modulation, bilateral motor integration using both sides of the body simultaneously, fluently altogether, motor accuracy, visual spatial issues, like for example copying from blackboard or taking out something from a cupboard, constructional practice, like for example looking at a certain thing and making it like from 2D to 3D. Oral praxis, which most of our speech language pathologists, they send lots of clients to us because they suspect the child is having oral praxis. So they are not able to verbalize, although they may have the potential to verbalize. Postural praxis, like the maintaining the body alignment and a particular tone, and praxis on verbal command. So here the word praxis means motor planning. So motor planning is the way of participating in a novel motor task, which is a new motor task. We haven't done it before. So when the demand comes in, we are able to do it spontaneously. That is called motor planning in very simple terms. So these are the things we generally see, we generally do assessment in our occupational therapy department. So moving on to the intervention part, and when we do the assessment, as I mentioned before, there are three key sensations, major senses that basically helps us to function adaptively. So first of this, I am going to talk about is tactile sense or the touch system. So the tactile sense actually it works as a protective or defensive system. Like whether we call it protective or defensive, it's same only. Like for example, all creatures are born with a protective defensive system. Like we feel pain, we get alert. When something touch on our hairy skin, we become very excited or alarmed. When the mosquito is touching our body, we know somehow get alarmed. So that is the protective or defensive part of tactile system or touch system. Another is discriminating system. Like second, what are we touching? The thing that we are touching are whether hard or soft. The thing that we are touching are whether they are uh, wet or dry, whether which part of the body the touch is happening, whether the touch is light or deep. All this information is received by the discriminative system. So what happens when there is out of sync tactile sense? So there are two terms that I am going to speak very repeatedly from now on. One is hyper-responsive or seeking, or hyper-responsive or defensive. And so hyper-responsive is, again, when we are discussing the brain as a filter, what happens is the brain filter with settle the body. So eventually the number of input the brain is registering not enough, that the child keeps on seeking more and more touch. Like for example, the child might be mouthing excessively, the child might be touching everything, the child might not be feeling little light touch. Second one is exactly opposite of this, like hyper responsive or defensive. So the brain registers even the slightest amount of touch. Like for example, even the tagline, the tag of the or the sticker on the cloth might appear very irritating. So like for example, they will avoid standing in a queue, they will avoid touching certain things, avoid touching play-doh, they will avoid touching food or bringing it to the mouth. Sometimes what happens is there is a mixed profile that we see. Like for example, out of the sync, it's not necessary that it will be only hyper-responsive or seeking or hyper-responsive or defensive. Sometimes there can be both hypersensitive or hyposensitive existing in the same client itself. Like for example, the child may jump when someone grazes his elbow, like touching it lightly.
Mansi, Mansi. Hello, Mansi.
Yes.
We couldn't hear you. Now we can hear.
Oh, I was not audible since a very long time, is it?
Not since a very long time. It's just, I think, to few seconds. Yeah, all right.
Okay. So till where I was audible?
Till the sensory part. I mean, about the oral part.
Okay. So I was talking about tactile. So tactile, it can be hyper-responsive when the brain is filtering out too many information. Hyper-responsive when the brain is registering even the slightest change, or poor discrimination where the body is not discriminating among the different textures. So for example, practical behavior, we can see that the child may put lot of items in his mouth, or because of the poor discrimination, he might avoid tasting certain kind of food because it's very overwhelming for him to process every time. So he may stick to one food, kind of staple food. That is just one example. There can be multiple things which can affect feeding. So there are the main issue that we see in tactile sense. So we'll talk about management later. Then the vestibular sense. So vestibular sense, again, as we know, it tells about head positioning, balancing, body positioning, so and movement. So sometimes what happens is our brain is not registering enough. So we are seeking, the child is seeking lots of movement. The child obviously may appear very hyperactive, running around, so may have a little bit of low muscle tone, and they are continuously seeking movement. the opposite might occur when the child is very defensive. For example, avoid getting onto any playground equipment, or may not prefer to play, become very sedentary, or generally they prefer to do every activities in one particular manner, because getting a new kind of information, a new kind of input for balancing and all becomes very difficult for them. So another thing which comes as a combination of proprioceptive and vestibular gravitational insecurity, there is a particular term when the child is particularly afraid of going against height, or like, for example, climbing upstairs, looking down from upstairs, or even like sitting on a high table, high chair or high table. So that is called gravitational insecurity. Then moving on to the most important and most vital sense, that is the proprioceptive sense. So as we mentioned, joint and muscle, all these receptors from joint, muscle, tendons and all work simultaneously, gives us the input that how to function or how to perform. So usually when the tactile and proprioceptive system that works together, which is also called somatosensory, we get like a particular output, like doing more like fine motor activities, like for example, lifting a glass of milk, or holding a pencil efficiently, buttoning up, or discriminating something like taking out 1 rupee coin from a box of marbles, like that. And second is vestibular proprioceptive, where the simultaneous sensation of head and body position when the person is actively moving is getting integrated. So all those kind of praxis that I said right now, motor planning, so it all gets affected when the proprioceptive sense is not performing correctly. So when there is out of sync proprioceptive system, obviously there will be poor motor planning, hyper-responsiveness or seeking. The child might enjoy falling, rolls, prefers hugging, get calmed by hugging, or when they prefer to wear tight dresses only. Poor discrimination is they are not able to discriminate between two different kind of pressure and movements. And poor modulation, again, because it's like an interplay. Proprioceptive sense basically helps in modulating all the other information, even for auditory, even for visual, everything, all modulation, the proprioceptive system needs to be in sync to have a proper modulation. Or again, hyper-responsive or defensive. Like for example, a child might cry on weight-bearing position, might not prefer to hold anything with his hand, avoid using the fingertips or lifting up objects like that. So these are the common things that we see, we assess when we do the assessments related to all the three major senses, that is the tactile senses, proprioceptive senses, and then vestibular senses. So when we are doing the assessment in our setup, what we try to do is we take as many information that we can take regarding this three information. So many times, like a problem which might appear a bit different might be because of poor interplay between these three systems. Like for example, oromotor or feeding issue, handwriting issue, being again self-regulation issues. So we need to take lots of information regarding the tactile, proprioceptive, and vestibular sensory systems. So again, these are the other problems that are associated with sensory processing disorder, which we commonly see. So these are all because of all like issues with the main three sensory systems because of the disruptions of it. So usually high activity level, as we see, though the child may become very very aimless, move very nervous, keeps on running, it becomes very agitated because they are not registering enough input, or the body is not able to understand. Then usually low activity level, because the brain is registering even the slightest amount of change. So very low activity level to feel safe. impulsivity for obvious reasons, again distractibility. These are all the problems that we see: problems with low muscle tone and motor coordination, problems with motor planning, lack of definite hand preference. So generally by age of 2 years we see emerging hand preferences, and then by 4 to 5 years it becomes established. So by the time the child is going to a preschool or a play group, they should show certain kind of hand preferences. But what happens is when the brain is not integrating adequate input, and there is poor interplay between proprioceptive and vestibular sense, there can be delay hand preference, and there might be lack of hand preference as well. Poor eye hand coordination again, then resistance to any new or novel situation, difficulty in making transition from one situation to another because it demands lots of information filtering, information enhancing, and information inhibiting and modulating. High level of frustration again because of the same reason. Self-regulation problem, as I mentioned, obviously due to the poor handwriting and poor attention. There will be academic problems, social emotional problem, auditory language problems, and then speech and articulation difficulties, vision problems, eating problems, digestion and elimination problems, problems with sleep regulation. Again, these things are a bit complex, so there can be more reasons to it. So I am not numbering it in the problems associated. There can be other reasons as well. So when we see we are not getting a clear-cut information from our assessment, so what we do is we refer them back to our consultant pediatrician, especially when there is eating problem, digestion problem, sleep problem, or problem with sleep regulation. So some conditions, again, I want to highlight a bit more. Like, for example, gravitational insecurity. Just now I said, have a great fear of falling even where there is no danger exists. So the child will be fearful all the time. So be fearful of heights, even slightly raised surface, become anxious when the feet leave the ground, feeling that even the smallest movement will throw her into outer space, will have motion sickness, be fearful of climbing or descending stairs, and hold tightly to banister, or may appear very protective. For self-protection, they try to manipulate their environment and other people as well. They might show behavior issues or temper tantrums. Auditory language processing, again, because they might seem unaware of the sound and location of the sound, so they might not able to look at us for eye contact. And again, they may have trouble identifying voices, for discriminating between sounds, which is functional sounds, meaningful sounds, and non-functional sounds. They may be unable to pay attention to one voice or sound without being distracted by other sounds, be distressed by noises that are loud, sudden, metallic, like, for example, pressure cooker whistle, or hair dryer, or drill, or something like that, which is very mechanical and high pitched. Have trouble attending to understanding or remembering what she reads or hears, although at that moment she might appear to have perfect hearing skill, but because of the processing issues, she might have difficulty in understanding and remembering that. She may interpret requests delayed, so he may frequently ask for repetition, and may follow only one or two instructions, and may have issues with sequencing. Then spatial processing, again, may have issues with looking at light directly, indirectly, may prefer looking at shadows, may have difficulty in looking at 3D objects around us. So may have difficulty in playing games where there is constant visual field is required, or having issues like copying from paper, matching jigsaw puzzle, and then confuse right and left, not understand concepts like up and down, like all preposition and all, will be very difficult, and may be uncomfortable, overwhelmed by moving object or people because it's changing so quickly visually. So now we are moving on the management. So the primary way of management is sensory motor approach, because sensory integration therapy is a bit more complex. It needs we need to follow all the assumptions of sensory integration therapy very judiciously, and then there should be like stations for vestibular, proprioceptive, tactile, and fine motor and all. So at times that is because of the space constraint and everything, we are not always using the sensory integration therapy. We are basically using the sensory motor approach, where we identify the child's problem, the sensory or the motor or the interplay between sensory motor, and we design sensory motor activities to tackle those issues. And then actually therapy is, as we all know, that we interventionists, we are only the guides. So main therapy that happens in is at home, how the parents handle the child, how the parents are following the sensory diet or home-based adaptive activities. So what is sensory diet? Sensory diet is like what we eat actually is diet, right? So sensory diet is the sensory amount that we are giving the child to meet his needs of own nervous system. Like for example, to be more focused, the child might need to have more organizing. To be more alert, the child need to have more alerting activities. And for example, to fall asleep and calm down, the child might need to do certain calming activities. So we prescribe the balanced sensory diet, especially to the parents who are able to follow it. We try not to overwhelm them, but at least we give them home-based adaptive activities, which looks more fun, more play, and there is no strict or rigid routine. So the parents can follow adequately at home and they can give us feedback. So the adaptive activities will be like, for example, it can be even as simple as catching and throwing a ball, standing on a balance board, or crawling under the dining table to fetch a puzzle piece or a vegetable that has fallen down. So we have a target of activities that we give us, like which is incorporated in the routine of the child, and they are able to facilitate an adaptive response through that activity. Then using prescribed gears, like for example, noise cancelling headphone, weighted vest to control hyperactivity, noise cancelling headphone when the child is too hyper responsive to the auditory input, so they have difficulty in filtering out information and they usually get overwhelmed. So we can recommend the noise cancelling headphones, weighted vest, so that the proprioceptive input is constantly applied to the body. There are protocols of giving weighted vest. It should be always used under supervision of therapists. Lycra bodysuit, again, it gives a control amount of proprioceptive input. And as you mentioned, Pritishmita just now, ASC, etc. So we request our clients to bring the ASC if they are using anything at home or during other therapy session to our OT session as well, so that we can elicit an adaptive response using that ASC. Like for example, they are asking for more, like during a sensory motor approach, I am doing a swing activity with the child with like for example, I am asking it, I'm giving him 10 rounds of swing. So the child is asking for more, no or yes, by using a ASC. So we request, it's always a team effort, so we request the parents to bring the ASC with them if they are using any. So we talk about sensory diet just now. So these are, I thought we'll have a few parents with us. So there are basic alerting activities as take-home messages, what they can try at home with the children. These are not prescribed activities. These are simple alerting activities that you can try with your child. And usually there should not be, because they are very basic and all, should not be very much overwhelming. At the same time, alerting means you should know where and how to use it. Alerting is always before an adaptive response you are seeking, before, like especially when we're giving a sensory diet, we give it towards the early half of the day. So it's like for example, bouncing on a therapy ball, jumping up, running to a target, dancing on a upbeat music, crunching on crispy things and chewy things. So these are certain which are alerting activities. So body gets more aroused, and after that they are able to learn and catch more. So when a child is coming to us, they are on low arousal level. So we give them alerting activities, and we recommend that they come to us before they go to speech therapy, so that the brain is more alert. They are able to receive more information, and they are able to integrate more information. Organizing activity, which is actually most of these activities are safe. Most of these activities are proprioceptive based, because as I mentioned when I was discussing about the proprioceptive system, it is like the balancing way between all the other senses. So most of the activities are proprioceptive activities, like hanging by the hands, pushing or pulling heavy loads, crawling inside a tunnel, getting into upside down position. So it's like intense vestibular proprioceptive input. a blanket or bedsheet wrapping or tight hugs. So whatever comes, like not calming, whatever helps the child sit down or focus better. So those will be the organizing activity. There are calming activities which are preferably done towards the second half of the day. Like for example, sucking on something like which is like a bit comfortable to the child, not necessarily lots of sugar and all. So basically a cold things to be more calming than hot. And then pushing against, again, is full of proprioceptive activities. So some of the slow hammock swing can be done because it can be very calming and relaxing. Rocking, swaying, again, it has to be done as per the supervision of the therapist and should be very slow and regulated. Deep pressure massage, deep body massage. I wrote deep pressure massage twice, sorry. And lotion rubbing, like dinner bath bed. If the child is following the routine, you can do a proper body massage before he goes to bed. And taking a bath with lukewarm water or aromatherapy as an adjunct. So for the parents who are here, there are certain bonus activity ideas for on the next 2 slides. So actually, I thought if we can interact, we could discuss a bit more, but we are running out of time. So these, the first one is should be done in the early half of the morning because it's ways to wake up our body. So it's more alerting activities like loud music, jumping on trampoline, like fast swing and all. And second one is more like organizing. So it's like all this proprioceptive, full of proprioceptive activities, like wiping the board can also be a very good proprioceptive activity. Carrying his own backpack can also be a very good proprioceptive activity. Then again, we should always try to do more proprioceptive and vestibular activities before doing the tactile activities because the tactile activities can be a bit too overwhelming. So these are certain examples of tactile activities. So these are the take-home messages, especially for the parents and junior interventionists, which I want to highlight. For example, if the child is showing any registration issues, behavior issues, or not doing a certain activity in a certain way that you expect, don't force. Create opportunities, give them time, model what is expected, follow sensory integration diet, SI diet given by the therapist. Then try to follow I play, like I am doing for you, then we play, let's do it together, then you play. Rather than, like, for example, a child is very afraid of, these are the practical real life experiences I'm talking about. The child is afraid of swing. The therapist put the child straight away on the swing. The child cried so much that they stopped coming for therapy. So it should not be like that. Like I am sitting with the child first, so we play, or I play, you see, you don't have to do, you just be here. Then we play together, or you play, like that. So especially with the defensive client, we need to be a bit more playful, we should take a slower approach, especially for tactile. Again, we should always follow I play, we play, and you play method. And forcing a tactile input on a child may backfire. It can even make the child more worse. So we need to be very mindful of using it. When the child is behaving in an odd way, always don't try to problem solve then and there. Wait, watch, and wonder why this can happen. Then try to share this with your Otis, and then let's it's better that we find a common way and find out, problem solve why it's happening. Then after that we try to solve it. Like for example, a child is looking at a certain object or flapping his hands. So instead of just asking him, saying no all the time, we wait, why he does it, watch and wonder, like try to solve whether he is seeking lots of proprioceptive vestibular input, or whether it's a behavior issue, or he only does when he gets excited because he's not able to show it in any other means. So we need to find out the reason behind it, and then only we should try to problem solve. So we should not, like parents say a problem and we straight away we try to problem solve it for them. Sensory integration therapy and sensory diet are not same. Sensory integration therapy and sensory motor activities are not same. Everybody has a slight different way of responding to stimuli, that is sensory processing. Like for example, I hate bright things, but that doesn't mean I have a sensory processing disorder. So intervention is only needed when it hampers playing, learning, or participating in activities or daily living. Difficulties with sensory processing is an indicator for autism. However, not all children with autism will struggle with SPD, but study shows that 3/4 of children with autism also have signs of sensory processing disorder. And again, certain kids may only have issues with sensory processing, so but they don't have autistic features or autism. These are my references. Thank you. The floor is now open for questions.
Thank you so much, Mansi. It was indeed a very nice and very insightful presentation. I mean, we really learned a lot. I have a question to you. What about the cornering of eyes? I mean, like when a child does cornering of eyes, so what happens a lot of time? The parents generally say they don't do that. That's how they. So, what do you think we should do when the child does a cornering of eyes in the session?
Okay. So again, as I said, watch, wonder, and then try to problem solve. So first we see why the child is doing it, whether the child has issues with visual processing, whether the child is avoiding the task or looking away from it, or whether the child is like, for example, sometimes it can be because there is formation of shadows when we look tilted, and such like especially while researching lots of autistic behaviors and autistic brain, it has been found out recently. I have read through this beautiful book of Temple Grinding, Understanding Autistic Brain. So she has mentioned, I haven't gone through the literature yet by myself, but she has mentioned that many of the autistic children, when they are not looking at you, they are actually looking at you. So when like they have compared imaging of a typical child and a child with autism spectrum disorder. So what happens is when actually the child is looking at you, they are more stressed. They are not looking at you, they are less stressed. So they are actually learning better. So the first and foremost thing is the OT should find out what is the reason behind it, and then try to problem solve. So I would like to know a bit more about the child. So if possible, yeah, so that we can create a more individualized sensory integration or sensory motor approach for the child. But generally, what I ask them, if there is lots of visual distractions, there are lots of light, or there's lots of shadows and all, we can straight away avoid that, because we are eliminating some of the causes there. And then facing on a like plain wall and on a corner, so that when they are doing lots of corner vision, they are not getting lots of what to say input from the wall. So eventually they are looking more at you. So that's handling the behavior part. One of the activities that one of my senior has taught me, actually that's a very useful thing that's working wonders with my kids. That means my clients, is giving them linear vestibular input, that is side to side. The therapist is sitting in front, so the child is doing linear vestibular, like side to side swing movements, and we are presenting lots of the things on the midline. So that also I have seen. This is not a prescribed activity from a book, but one of my senior has mentioned it, and I have seen wonders doing that activity.
Thank you so much. Thank you. Any other questions?
Thank you, Dr. Raj. Thank you, Chandana. Thank you, Sandamita. Thank you for joining us today. Any more questions? See, all of us, we have certain visual, like what to say, sensory processing issues. Like my visual processing is very bad. I have difficulty reading from like screen. So that is okay, until unless it's not hampering when I am, for example, giving a presentation. I might fumble a bit, but that is okay because I'm managing it fine, right? The same is applicable even for the child. Like the child is a bit sensory defensive, or they are not eating certain kind of food. Like the parents come and ask, he doesn't eat chocolate or chips, but he is eating the staple food. So it's not necessary that everywhere we give intervention. So if that the chief complaint of the parents, yes, definitely, so that we handle them emotionally, psychosocially, and demand their follow their demands. So we try to definitely tackle that, but that won't be our primary goal. Our primary goal will be what we find out from the assessment, and then primary goal will be what is the main, like the chief complaint of the parent. So we try to, when we are giving the home-based intervention, we try to give lots of, not overwhelming, but adequate amount of home-based activities as well. Nazia Sultana, ma'am, do you have a question?
Yes, ma'am. Actually, I have a daughter who is deaf as well as autistic. We have done her cochlear implant in Pratiksha Hospital only under Dr. Vishwanath sir, and she was very early diagnosed with autism also. And I can see that she is also having very severe sensory processing disorder. The she has a lot of issues, but main issue is whenever she wakes up in the morning, she cries out like hell for another half an hour. This is
Hmm.
it becomes very difficult to manage her. She becomes very aggressive,
Very cranky.
becomes cranky,
Hmm.
becomes self-injurious, and she has a lot of vestibular issue also. I just wanted to ask, is this vestibular issue related to her, like, because she's not uh, have a natural hearing, that might be also one of the reason, or
Yes, it is suspected that way, but more researches are needed to confirm that. But we have seen clinically that lots of the children who are having cochlear implant are, most of them, they tend to be hyperactive. So maybe because they are sensory deprived during a very early age, so their this whole vestibular cochlear system is not functioning very well. So later on, the brain is filtering out too many information, and they need more information to meet the need of the body. And sometimes what happens is, because the brain is constantly working too much, the child may show behavior like being cranky, because every day she wakes up, it might be lots of new information for her to process altogether. So you can discuss a bit more with your occupational therapist. For example, might be for in the morning for her, it won't be alerting activity. It will be more organizing or calming activity, something more relaxing. Give her time. Probably if she is not still she is not very good with her verbalization or following verbal commands, as Dr.
her
Bora or
understanding level is very
Patri
poor,
Shruta
ma'am.
suggested, we can give visual aids as well. So give her a particular routine so she knows what is expected of her, and so that it doesn't change very frequently, doesn't change every day. And try to do more calming activities. And then when she is showing more arousal, you give her activities which are more demanding. Even brushing can be a bit too demanding for the kids. Sometimes what happens is, when the child is getting up, because there is issues with sensory processing system, the brain is not aroused altogether. So they seem to be more alert or more active towards the second half of the day, which should be the other way around. So we should do proper management of the sensory diet.
Okay, ma'am. Thank you.
Parag Bossa, yes sir, মই definitely try কৰিম. আপোনালোকে যদি বিচাৰে মইতো slide টো মই share কৰিব পাৰিম আপোনালোকৰ লগত। কিন্তু কি হয় ন, যেতিয়া গোটেইখিনি মানুহ ইংলিছত মানে ক'বলৈ সুবিধা হয়, ইংলিছ ইজ এ ইউনিভাৰ্চেল লেংগুৱেজ, তো সেইটো কাৰণে মই ইংলিছত ক'লো। আৰু একচুৱেলি শ্লাইডটো একেবাৰে চিম্পল আছিলে। বেচিকেলি মই এইটোৱে ক'ব বিচাৰিছিলো যে ব্ৰেইনে কেতিয়াবা বহুত বেছি ইনফৰমেশ্যন ফিল্টাৰ কৰি দিয়ে, কেতিয়াবা একেবাৰে একোৱে ফিল্টাৰ নকৰে, তো গোটেইখিনি একেলগে পাওঁ। তো সেইটো কাৰণে আমাৰ সব এডাপটিভ ৰেছপন্স, মানে আমি এপ্ৰপ্ৰিয়েটলি কাম কৰাত শিশুটোৰ অসুবিধা হয়। তো অকুপেশ্যনেল থেৰাপিষ্টে আপোনাৰ সেইটোৱে চাব যে কিহৰ কাৰণে কাৰণটো কি, কিহৰ কাৰণে হৈছে, তাৰপিছত আপোনাক জনাব যে ঘৰত আপুনি কি কৰিব লাগে, নাইবা থেৰাপিত মাতিব আৰু এক্টিভিটিজ যি যি দৰকাৰী হয় সেইটো মেনেজমেণ্ট প্লেনত ৰাখিব। Okay, sure. I think we are going way beyond the time. It's 30 minutes past our scheduled time. Sorry for making the presentation very lengthy, but it was such a vast topic. I didn't know what to cut off and what to include.
It was indeed very informative, Mansi. I think somebody wanted to, Miss Apti Bhattacharya. Ma'am, please ask your question.
Hi, Mansi.
Hello. Hello, ma'am.
Hi. I have a son who is 6-year-old. So since he is diagnosed with ASD and probably ADD as well, what I have seen since childhood, he had aversion to food. His diet is very limited. As in, he doesn't want to try anything new. So what happens is, say, just in case I still have to feed him with a spoon. So just in case I give something to him with a spoon near his mouth, as soon as I take, he tries to shrug it off, or backs out physically from the spoon. Or say I give him a piece of biscuit or cake or anything, he would not even take it in his mouth. Despite of showing him in action, he would not put anything in his mouth.
Okay,
So
does he do food play? Have you tried doing food play with him?
Earlier, I used to give him a plate with food, so he would touch a bit, and then he would make he would shy off. I mean, he used to feel, I guess, disgusted or something. I guess he has sensory issues because
Okay.
it's sticky with dal and all. But when I say I give him a piece of cake, instead of putting in his mouth, probably if I show him, indicate him once or twice would be the maximum. He would then crumble it and throw it off. And anything
So
I
he
want
has difficulty with chewing as well.
chewing, I'm not sure, because if I make him, if I give him apple, say like a French fry cut apple,
Like
that
crunching, he is okay to chew.
yeah, that he chews, and he chews everything else. Mouthing is constantly there. Grinding of
So
teeth
it
is
looks
there.
like a, ma'am, it looks like a mixed profile of oromotor issues. So
Okay.
it will be very difficult to explain it to you over here because it's going to be very lengthy.
Yeah,
I would
yeah.
be happy to help you if you reach me personally.
Okay, thank you.
I'm
Thank
available
you.
in Pratiksha Hospital. You can reach me out here.
Thank you for your lead. Thank you.
All right, I think we can wrap up here. So any other questions? I hope there's no other question. And if there's any other question, you can mail it to us. You can mail it to Pratidhwani at Pratidhwani info at the rate Pratidhwani at the rate info.in. So you can mail it to us. So so I'm very happy. This is our second year. Pratidhwani has conducted the ASD webinar. Last year also we had a very grand success. This year also we had a very nice talks. Thank you, Dr. Prathapatim Bora, and thank you, Dr. Mansi. And thanks to all the participants for joining us this Sunday. And all the parents there, I would like to say maybe by another next week or two, we will have one more webinar on how to reduce screen time or what to be done instead of screen time. So that's a very fast talk. It'll be by Miss Shweta Utkalika. So she is a speech language pathologist. So maybe in another 2 weeks, maybe next week I'll put up the brochure when we are going to conduct it. So we'll hope we'll see there again. Thank you so much, everyone. Good night.
Thank you. Good night.